Hi, everyone. My name's Chad Cook. I'm with the Duke Center of Excellence for Manual and Manipulated Therapy. And we have another shop talk. Today we have Casper Nim. And his paper was recently published in Nature Scientific Reports in 2022. The title of the paper is The Importance of Selecting the Correct Site to Apply Spinal Manipulation when Treating Spinal Pain, Myth or Reality. And it was a systematic review. And with almost all of our papers, again, this is available open access. Casper, welcome. And can you tell us a little bit about yourself? Tell us your clinical background and your interest in research.
Well, thanks, Chad. Well, I'm a chiropractor by training. I completed the master's program at the University of Southern Denmark in 2016. And basically, I knew when I was a master's student and also doing my clinical residency that I wanted to go into research. So I actually started preparing my PhD project back in 2016, 17 or so, and then I completed it in 2021. And currently, I have two employments. I'm employed as a researcher at the Spine Center of Southern Denmark. Well, I should say researcher / chiropractor. And then I'm an assistant professor at the University of Southern Denmark.
I've read a good bit of your work around manipulation, and I've enjoyed that. And you said you had a kind of an early thought process that you knew you were going to get a PhD, or you were interested in a PhD. Did you know you wanted to study force-based manipulation as well?
Well, that actually was more or less just something I fell into. I got to be honest, up front, I knew that I wanted to do research. So I basically did what any Danish chiropractic student at the University of Southern Denmark would do, which is to go and talk to Professor Jan Hartwigsen, who obviously is an epidemiologist, and he presented different projects. And I really wasn't that much into the epidemiological aspect. And then I met who became my supervisor, Søren O'Neill at the Spine Center, who does a lot of pain research. And I was intrigued by this experimental setting, and then we went to Greg Korchak and we set up this manipulation project. So I kind of fell head over heels into it, but I don't regret it one bit.
And I know you did a randomized trial as part of your PhD training too. It's a relatively large randomized trial too, and a good one. And I know we're going to talk about the systematic review, but I just want the listeners to know that you've also got a really good trial out there. Can you give us a 1-minute overview of what you found in your RCT?
Yeah, absolutely. And one thing that's important to remember when we talk about the review later is that our results from the RCT, they actually come in parallel to the review. But we basically had the understanding that we wanted to understand more about the segmental mechanisms. So we used two different approaches to measure stiffness and to measure tenderness at each lumbar vertebra. And then we basically randomized participants into receiving manipulation at either the stiffest segment or the most tender segment using a somewhat complex algorithm. And when we provided 4 sessions of manipulation in these low back pain patients and looked at the, I gotta say, short-term effects, which of course there weren't any, no difference at all between the two groups.
Yeah, that was a good trial. And again, I think when you're studying for a PhD and you get in the hundreds as far as recruitment, that's really impressive. So good on you.
Thanks.
In your systematic review, and one of the things we love to find out, what was the impetus behind wanting to study this systematic review and looking at targeted versus non-targeted segments for manipulation? Whose idea was that? What was the discussion at the table about that?
Yeah, well, Chad, it's a fun story, and I'm going to give it to you. Before I began my PhD, right, we looked at these different studies, and there weren't a lot out there at that time, which was back in 2016. And then, more and more studies actually came out during my PhD period, and then the PhD project in Denmark it's a fixed time. You do 3 years, and then you're done. And you have a protocol up front where you say you normally would produce 3 papers. That's the main idea. And then this stuff keep happening on social media, and people are going back and forth. And then when I was about 5 months before I had to hand in my PhD, I actually got the idea that, this could be super fun to actually synthesize the literature on. So I called Professor Charlotte Ude, who is just an extremely knowledgeable woman, a great mentor of mine. She wasn't a part of my PhD supervisors, but a great coworker. And I threw this idea out to her, and she was completely on it. And then we went to Aaron Downey, who did all of the second author stuff, independently screened the literature, assessed the papers, and risk of bias, and all that. And we basically got the review done in 4 months, so I could have a first draft in my dissertation. And for everyone who has done a systematic review, 4 months is, I mean, we really put a lot of team effort in it to get that done. And I got to say, the first draft looked a lot different than what we actually published. But yeah, we did all of the risk of bias assessments, the literature screening, and all of that within those 4 months. So that was a big kudos to especially Aaron Downey, who was absolutely amazing. But it came on as a tail project. I didn't plan to do it up front. So within those last 4 to 5 months, I got pretty busy. Luckily, it was not luckily, but it was during the pandemic, so everything was shut down. So I was just at home.
It's interesting. Usually, you do the systematic review first, then the RCT. So it's really interesting to hear that backstory. Great set of authors on that paper, by the way. And I've just recently got a grant with Greg, so I know him fairly well. But why don't you tell us what you found in your systematic review? This is, I think, the interesting part.
Yeah. Well, we searched the literature in 4 different databases, and I believe we got around 4,000 hits or something like that. It was a pretty broad search. Didn't have a lot of inclusion criteria other than it has to be randomized trials where they compared manipulation at what we defined as a candidate site compared to a non-candidate site. And this candidate site could be, it was the clinically relevant site, and it could be clinician determined, it could be determined by a protocol. And then we compared it to basically whatever they compared it to. And we ended up including 10 studies for a synthesis. We weren't able to do a meta-analysis on it because, well, the studies differed quite heavily in both the methods and the populations, and so we actually decided that we weren't going to do anything on it. And often you would probably say that's a weakness of a study because you can't do any statistics to say certainty and grade and all that stuff. But we actually kind of find it as a strength because, like, completely independent of how we looked at it, at least 9 of these different papers, right? They basically didn't find any differences at all between these two groups, no matter how they looked at it. And the one study that did find a difference, it was tiny, and it was the weakest study, I should say, quality-wise, and also the one with the lowest sample. So yeah, it's no matter how they looked at it, right? It came out the same way, no difference between the groups.
And your groups were PTs, chiros. I mean, I've read the paper obviously several times, and so I agree with you. You've got it really heterogeneous, but it's important because it covers it at all angles. And so you got a number of clinicians on your paper. Was anybody surprised by the results that you got?
I got to be honest, I don't think we were that surprised about the results itself. What we were surprised of was probably how many papers there actually were. Like, we knew 7 of them up front, I believe, but then we ended up including 3 more, which kind of took us by surprise. We thought we were, pretty well onto the literature, especially we had Stephen Pearl in there, who's a fanatic, right? So we were kind of surprised about that. And the second thing we were surprised about was actually how well done or completed these studies were. Like, they weren't poor or bad quality or biased studies. They were actually pretty decent. So I think that's probably what we were surprised about, the strength of what we could conclude on and the basis of the review. But the overall findings itself, as I mentioned, we knew 7 of the papers up front, so I don't think we were that surprised about it. But the way we could conclude it was a little bit surprising, considering
yeah,
10 papers.
So I'm aware of 6 papers in the joint mobilization literature, and I think 1 or 2 of them are mine, and none of the 6 have actually found any difference between a candidate site versus a non-candidate site. And I know you've done some mechanisms work before. I mean, what are your thoughts about joint manipulation versus joint mobilization? Do you think they have common mechanisms, or do you think it's different?
Well, I think, and I got to be upfront, that's not my area of research here, but I think in animals, there are different mechanisms, right? When you do oscillation or mobilization versus a high-speed thrust into pigs and cats and stuff like that, and you measure different biomechanical and neurophysiological aspects, I do believe there are differences there. But translating that into humans, I don't think there's going to be a lot of difference there. The way that the spine works biomechanically, you can't really get these intersegmental motions, as we kind of would expect looking at the textbooks. So overall, I don't think there's a lot of difference in it. Also, both of these therapies, especially manipulation, I would say, is surrounded by all of these contextual factors. I mean, for some patients, it's probably highly important that, you get the pop, you get the thrust and all that. And for other patients who might be scared of it, right? Joint mobilization is probably the better way to go. So I got to be honest, I don't think there's a lot of differences mechanically on humans. And I think it's driven largely by the contextual factors. And as you mentioned, right, we see that in the papers as well, the papers comparing grade 5 versus grade 1 through 4 mobilizations, right? They basically come out, some of them come out favoring manipulation, some of them come out favoring mobilization, but the majority comes up suggesting that there is no difference. And that has been highlighted in recent systematic reviews as well, that there are no clinical difference between those. So there might be some mechanisms that differ, but for humans, I don't think that they matter all that much.
I think you very well said that. And not that it matters, but I 100% agree with you on that. Let me ask you this. How much pushback, I mean, you're on social media, how much pushback have you had from the clinical population who just might say something like, I just don't see that in my clinical practice, or I don't believe the research? What have you experienced?
Well, if we take it back from the top, I think the paper came out on a Friday, and then as I often do, I pushed it quite heavily on social media, and we all did. We made a little video abstract and we shared it on a bunch of different forums. And I kind of feel like that we're obligated to do that as researchers on public funding, right, to get that research out there instead of they're going 10, 15, 17 years, right, before they actually are included or implemented into clinical practice. So I do think that's an important point I just want to say, but we did push it quite heavily out there, and we got a lot of, I mean, I'm almost on the verge of saying hatred back. We got a lot of negative feedback from especially clinicians who couldn't see it, right, because they see every day in their daily practice that the application side is highly important, and it's important to be specific with manipulation. And so, yeah, the clinicians, they simply didn't agree with us. And much of that, that's actually kind of interesting from a different perspective, right? A lot of the negative things came in the public chat, right? I think I spent, as I said, it came out on a Friday. I think I spent the entire weekend on social media responding to criticism. And, and it was, being a young researcher, it was kind of interesting and challenging a little bit. I definitely needed that extra glass of wine Saturday night, but it was a good experience, and we also received a lot of positive feedback, especially from researchers. Basically, all of my research colleagues, approached me and was like, we support this, and et cetera, et cetera. There were also clinicians who came and said that to me, but interestingly, that happened in the private chat. All the positive feedback happened privately, while all the negative feedback, it did happen, publicly. And I thought that was very interesting. I don't have a good explanation for it, but that's social media for you, I would say.
Oh, that is social media. I've experienced that myself, and your supporters will hide, and then the people mean tweeting from their kitchen are, they're all over that. And the way I feel about this, you did such an eloquent job in your discussion explaining why the findings were not condemning clinically for manipulation. I mean, you talk really nicely about its non-specific mechanisms and that it's very subjective, the targeted site, and then what you mentioned earlier, contextual factors. And then you went on and mentioned about training. So what are your thoughts about, I mean, based on this, how would you change your training that you've received in chiropractic And are these findings not somewhat liberating for a trainee to know that they don't have to have the golden manipulation?
Well, and that's what I thought initially, right? We do have a small section in the discussing education, and to begin with, that section was, I initially wrote it 3 to 4 times that length because that's really why I wanted to do the study as well, right? I mean, I do work with students almost every day, teaching, supervising them in clinical settings. I'm a clinical coordinator as well from the university, so I think that was the important aspect of it, because someone who has been out in practice, say 20, 25 years, right? We're not going to change anything based on this review, and we probably shouldn't, because there weren't any differences between the groups, so they can go ahead and do what they wanted to do. But I think in an educational setting, right, we could remove this underlying theoretical aspect that we are locating something specifically and then we are fixing it, almost, you said liberating. I always want to say the same thing, right? We're liberating the joint from whatever is causing this fixation. And that just doesn't happen. There's no evidence to suggest that actually happened. So we kind of thought that this was positive, right? I mean, students could be better prepared to actually provide a long-term management plan and strategies that involved multiple different aspects, learning how to be a gatekeeper for low back pain, and all of the stuff that we really need socially, right? I mean, we need to ease the load of our general practitioners, etc. And we need to be better and do better. And I think we could free up time in the curriculum by decreasing some of all this theoretical motion palpation and all of this stuff here behind it. So that was basically my idea. But I just want to say, I don't think there are probably some aspects of manipulation that are important. It is a skill that needs to be developed, and that does take time. And there are actually pretty good evidence to suggest that factors such as the preload, the dip before the thrust speed, the amplitude, the hold following, patient placement, line of drive, all that different things, right? That's things we can modulate, and that's things that needs to be taught. So it is a skill that has to be learned, but we could probably cut down a little bit on how long we actually takes to teach this, and then focus more on the psychomotor skills training, the patient placement, and then just let students learn different techniques that they can basically apply directly in clinical practice, instead of us having to go through restricted sections and all of these different theoretical frameworks. That doesn't really make any sense, especially the vectors of it, like trying to apply it in a lateral flexion and a rotation and stuff like that, right? All of the forces go directly posterior to anteriorly. So there's really no point in thrusting other way than just directly anteriorly.
I think that's very well put. And you mentioned something that I think is important about, you can be a gatekeeper, you can be on the front line of care, you can manage low back pain appropriately. There's clinical effectiveness evidence for spinal manipulation. There's cost-effective evidence for spinal manipulation. And that piece does not change with the findings of your systematic review. And I think that's a really important piece. It doesn't condemn spinal manipulation whatsoever. I have a couple of questions for you regarding the methodology. And one of them is I think you had mentioned that a limitation was the fact that they didn't study whether or not the patients knew if they were blind, were they blinded to which group they were allocated to, or the candidate side or non-candidate. Do you think it really affected the results of the study by not studying that?
I think we eliminated the aspect of blinding because we had an idea that, especially when you go across regions, blinding would be basically impossible. So instead of what we looked at was whether they included naive patients. So patients who hasn't earlier experienced manipulation. None of the studies said anything about that. And if anything, right, it should enhance, or I mean, it does put a bias towards the candidate side, actually, that, especially in the 2 studies by D. Oliveira from 2013 and 2020, where they take patients with long-term low back pain, and then they randomize them between lumbar SNT and thoracic manipulation, and again found no difference. Despite that's probably the best study that was in the one from 2020, right? It was a full course of care, long-term follow-up. It was a good RCT, And again, it didn't find any differences at all. So I don't think it matters that much. I think it matters more for clinicians than it matters for patients. And then again, for some patients, it may matter a lot, but on the average aspect, I don't think it matters that much.
You mentioned the Oliveira, and I think that was the one that had the longest term follow-up. I think the majority of the studies only involved one manipulation. And as a clinician, do you think that influenced the results? And I know there were others that there were two manipulations, et cetera, but what are your thoughts on that?
Oh, I think it's a good critique, first and foremost. But if you want to study the mechanisms behind SMT, there are so many contextual factors surrounding the course of care. Pain is highly fluctuating. There's a natural course of history, right? We expect to see complete improvement basically pretty fast. And that's independent of whatever modality that you're actually examining. So I would probably provide the counter argument saying that if you want to look at specifics of manipulation, and in our case, the application site, then you want to do it one session, because whenever you do it more than that, right, natural course of history is going to take over. And we do see it in placebo-controlled trials as well. That's another one of my arguments that I always make when I get this question, which you can hear that I've gotten a lot, is that, the effect of actual manipulation versus a placebo or sham manipulation it's tiny, right? It's very, very little on average. So we have to understand, or we have to at least, I want to say appreciate almost how much of this little effect actually can be contributed to that specific application site. And that's another point that we actually didn't make it in the study. I think we probably should have in retrospect, that there's probably not a lot of effect that can go into the actual application site. And all of these studies here would agree with that, whether they looked at one manipulation or they looked at 10 manipulations, or whether it was a chiropractor or physio who provided the treatment.
I'm with you. I think, I'm a clinical training, I'm a physical therapist, but I think the majority of our treatments have small specific effects, but relatively large contextual effects. And so I agree with you. So you published this paper in Nature Scientific Reports, a pretty high profile platform. You had a really nice rollout on social media. What makes you most proud of the work that you did here? And you did it in 4 months.
Well, we did write it for 6 months following my PhD, and then but we did get the framework in a short time, which I am also proud of. But I would probably say what I'm most proud of is probably, it's something probably stupid for some, but the pictures that people send me, like different lecturers and teachers basically around the world, they sometimes send me these pictures of their technique class or their mechanism class, and they have a my front page on their PowerPoint and say, look, Casper, we're discussing your study. And I think that's probably what I'm most proud of, that we actually are making an impact. Instead of teachers just completely ignoring us, turning on the shutters and just go their usual route, they do present this to students who has to live in this world afterwards and have to go through this maze of uncertainty surrounding both their education and especially manipulation. So that does a lot for me, I gotta say. And also just I talked to, I believe, 4 or 5 different schools, universities, colleges, whatever, about my paper. I also think that's also that's good to see. I'm really glad about that we're actually making an impact.
Well, you certainly have. And I read somewhere where 55% of papers are never even cited that are published. And then you had such an outpouring of interest in your paper. That is a pretty amazing thing. If you had, let's say you were in an elevator for 1 minute and you had to talk to a person responsible in the government for paying for a spinal manipulation, what would be your 1 minute elevator talk about your study and its relevancy to its use in clinical practice?
Well, I would probably say that my study builds upon what we already know, as you mentioned, right? That manipulation is recommended in clinical guidelines, and we do have cost effectiveness of it. and if anything, right, this would open up the door for more patients to have it, right? Because we can basically extrapolate these findings out to more sinister low causes of low back pain, disc herniations, and perhaps even compression fractures, right? I mean, you can go a little bit gender, a little bit further away, and kind of still expect the same results. So I think that's a positive. And then when looking at, across my study, I would probably say that the good thing about manipulation is that, it's fairly easy to predict, 4, maybe 6 visits at max, right? We're going to know who's going to respond or not. And a lot of people, if they haven't tried it before, they will respond positively, as you mentioned. So I think it's definitely worth the try, and they can send it out to whatever therapist that applies it, whether that's a chiropractor or physiotherapist or osteopath or whatever it is, right? And they can go ahead and get a short course of care, and if that makes a difference for that patient, that's good. That's basically what my paper provides, is that we don't have to be that specific about what we're actually doing here, about the application side, or about what people are, what their cause of low back pain is, if we can find such a cause. And that's probably the main takeaway. But right. I also got to be honest here, Chad, if it was completely unimodal and that was like manipulation, then get out of there. I probably wouldn't recommend that for anyone, even in an elevator. As I mentioned, manipulation is a good strategy. There's a lot of patients who are in some kind of maintenance care program where they can manage, completely self-manage, and then having to go get manipulated 4, 5, 6 times a year, and that's fine. They can play their golf and go to work and all that, and that's great. For some people with more disabled low back, who does cost the society and insurance agencies and etc. money, it is a valuable thing to include in your strategy or your management plan. I don't think there's any evidence to suggest that it isn't. But the theoretical groundwork of it, that's where we have to be careful, right?
100%, 2 different things. Completely agree. Hey, I know you're super busy, and I know you've been talking about this one a lot. I really do appreciate you sharing your work with CMET. You mentioned that you were on Twitter. Do you mind sharing your Twitter handle and any of the other social media sites that you might have?
Yeah, I am. I do have a Facebook, but I don't really use it that much. But on Twitter, it's Casper G Nim, at Casper G Nim. So basically my name, and I do attempt to put up, or at least I do put up all of the work that I do, and I share some interesting studies and a little bit of a statistics as well. Do some programming and stuff like that. I do tend to share that. So if that's your interest, that's a good place to follow, right? For manipulation, and right now I'm diving into the more complexity of long-term pain trajectories. We just had a paper accepted into Pain about the self-reported visual trajectories, which is also something I'm working on and will publish a few papers on over the next couple of years here. So if you're interested in data manipulation, that's basically what I'm probably going to do for the next couple of years.
Well, I appreciate you letting us know that, and I follow you on Twitter, so I think you're a good follow. And thanks again for your time. And I think this went great. I think the listenership is going to be very interested, and you brought up a lot of great points. Thank you so much again for sharing your evening with us.
Yeah, you're welcome, and thanks for inviting me. It's a pleasure.